developed refractory hypotension. He had a cardiac arrest on 23rd November and he passed away. So the final cause of death was septic shock and multi-organ failure with leptomeningeal carcinomatosis, complicating an advanced stage signet ring cell carcinoma rectum, which was operated. So we can, for discussion, we have two things. One is a signet ring cell carcinoma in the young, and leptomeningeal carcinomatosis of signet ring cell carcinoma, which is a very rare complication of a rare rectal carcinoma. So there is a review article based on primary signet ring cell carcinoma in the colorectum. It's a case-based review done in Bulgaria and France. So colorectal signet ring cell carcinomas are very uncommon, and only 0.1 to 1% of colorectal neoplasms account for them. And there is no difference between the Western and the Eastern countries. And these colorectal signet ring cell carcinomas occur at a younger age and at an advanced stage. The presentation is a little vague, and by the time they are detected, they have reached an advanced stage. They are associated with a high lymphovascular invasion, distant metastasis, a more malignant biological behavior over the other ordinary colorectal carcinomas, and it predicts an overall poor survival, as was the case in our patient. In fact, the 5-year survival is only documented to be 58.1%. Leptomeningeal carcinomatosis and colorectal carcinoma, this is a Mayo Clinic experience. They have done a study, it's a meta-analysis, which has been done over 15 years, from 2000 to 2014, where they studied 17,095 cases, and only 10 cases showed leptomeningeal carcinomatosis, which brings it to about just 0.058%. And the median survival after this is only 7 weeks and can range between 2 to 39 weeks. And the poor prognostic indicators are a bulky leptomeningeal disease, concurrent CNS disease, epidural compression, and poor performance status, so few of which were present in our patient. And there is another case report, which is quite similar to our case, wherein a 37-year-old male with stage 4 rectal carcinoma died within 3 months of diagnosis. So if we, with the review of literature, if we try to compare it with our patient, review of literature says that rectal signet ring cell carcinoma present at younger age, which was there in our case. Our patient was 39 years old. They present in right colon and rectum. Our patient had a rectal adenocarcinoma. Most of these signet ring cell carcinomas are in the lower rectum, resulting in high APR, which was the case in our patient. And they present at advanced stage 3 and stage 4. And yes, in our patient, it was stage 4, and they present with very high rates of LVSI and lymph node metastasis, which was there in our patient. And a CRM of less than 1 millimeter can lead to local recurrence and decreased overall survival. And in our case, CRM was just about 1 millimeter. So to conclude, in this case, a signet ring carcinoma is a very rare variant of colorectal carcinoma. And as compared to other conventional adenocarcinomas, signet ring cell carcinomas have a younger onset. And but they are diagnosed at advanced stages because of their vague presentations. And prognosis is very poor, even if optimal treatment is given. And again, leptomeningeal carcinomatosis, as in our case, is extremely rare in colorectal carcinomas and is definitely associated with very high mortality, and it has a very grave prognosis. Thank you.
Thank you, ma'am. Before I open the house for discussion, ma'am, maybe a very stupid question. Signet ring cells, as per the tumor marker, is CA also along with it associated?
Yes, so CA can be raised in signet ring cell carcinomas. Basically, signet ring cell carcinomas have a loss of E-cadherin. The CHD protein, the CHD gene is mutated. So the cells, they lose their adhesion, sir, and that is why they are more motile and shows an aggressive behavior. But they do produce a CEA.
I think also I may add on this. Why there were multiple PET scans which came negative. The sensitivity and specificity for a poorly differentiated adenocarcinoma FDG is very good. But for a SRCC, the accuracy goes down drastically. They come as false negatives. Any clarifications, questions? comments from the
Sir,
GSP.
you are very well presented, but for the residents, we must go back with the learning that if we have a young male who's 39 years old, we must probably think of Lynch syndrome. And intra-ileal Mets probably may have been present earlier, in my opinion. This may be a type 2 Lynch. And the family history should always be brought out. During the initial surgery in a non-metastatic setting, we must look for a MSI and MSH, MMR. So that means we look at MLH1, MSH2, MSH6, and PMS2. These should be looked at. And when we report the final histopath after surgery, other than the chemotherapeutic response, we need to look at tumor infiltrating lymphocytes. So if the tumor infiltrating lymphocytes are present, the MSI is high, this leads us towards a Lynch syndrome. And if it's a Lynch syndrome, it would probably get therapy with the immunotherapy. They would do better. So one is the history taking. It's not the fault of the presenter. It's probably the incompleteness of the documents. And the second part is the CA levels must always be mentioned. The final part, I feel the one which went to the leptomeningeal spread and all is a part of a disseminated disease. So it's just semantics, whether how many percentage in the world are present and all. The more important thing is probably to start better in the beginning. The other thing was the coccyx, which had involvement of tumor deposits, is a controversial area in rectal cancers. When we look at the CRM being less than 1 millimeter, they always do badly.
Thank you, sir. So MMR was done, IHC was done for same, and it was MMR proficient. So that was done initially also in 2022, and we also did it.
2021.
So, yes, sir.
And then the family history also needs to be looked at, because now in 2024, as you may be knowing, the Oxford group has launched a Lynch vax. So there's a vaccine in case the thing was positive.
Thank you, sir.
Excellent case discussion, ma'am. Adenocarcinoma in young is not that rare. We do see signet ring cell differentiation in almost 50% of adenocarcinoma, but we label it as poorly differentiated adenocarcinoma with signet ring differentiation. When we get more than 50% differentiation, then we call it signet ring cell adenocarcinoma. As sir said, they are different molecularly, because as compared to conventional adenocarcinoma, which are KRAS associated, it is more of a RAF and MSI. So MSI was done in this case, which was MSI proficient. And about the marked dissemination into the brain and all, in most of the cases in MDTC, we know that these cases are having multiple, mets at different sites. So most of the time, our approach is more of a palliative, and these kind of cases usually doesn't undergo autopsy as done in this case. The interesting part in this case is, till the end, it was considered as a T3 lesion only, and we could not prove basically metastasis prior to the postmortem. That's why probably we could see and demonstrate this kind of a dissemination in this particular case. Otherwise, most of the adenocarcinoma cases, when died, they die like this only, sir.
Yes, very nicely presented, Group Captain Pragya and Colonel Bansal, sir. One point, sir, as Chaudhary sir has said, the family history, but I would like to emphasize to the resident that I think performance score was not told to us in this clinical presentation. And as he's a young guy, but with the geriatric oncology we coming up, the performance, functionality, palliative intent, all those things. Yes, this case was not diagnosed to be disseminated malignancy at this stage, but these are the aspects which are very important to be seen, especially the performance scale in the younger population.
Just wanted to highlight a few points, sir. The most important thing is, once we go ahead and look at the histopathology report, it was YPT3 and N1A, and coccyx, there were some deposits which were present with a signet ring morphology, which is an aggressive morphology. We know that the cells are floating all over the body. You expect such a outcome in such a patient. So whether the patient is labeled as metastatic or not, here it was definitely grossly metastatic, because there were coccyx deposits which were seen. So whether labeling or not, it's probably immaterial, or probably one could go ahead and say